Next slide, please. So let me introduce Dr. Professor Tufan Pati sir. He's from Cuttack, National Advisory Board member of IPP, Chairman, Membership Subcommittee of IPS, Life Fellow.
You can be brief. Huh?
Okay, sir. Over to you, sir. Over to you.
So we must have time to listen to the speakers and inputs by the eminent chairpersons. So with me, we have two moderators, Dr. Amrit Joshi, who is a neuropsychiatrist and he professor of psychiatry in High-Tech Medical College and a consultant in Army Hospital and Healing Trust Clinic. At present, he is a direct council member of IPS and he is the editor of Odisha Journal of Psychiatry, which is indexed. And he's chief coordinator of UNICEF WHO IPS initiative and telemedicine since last COVID outbreak. And we have got with us Dr. Alim Pattojoshi, who has been there since the beginning. You must have heard him. He is a neuropsychiatrist, psychotherapist, and wellness consultant. He is professor and chief consultant neuropsychiatrist high-tech. He is director Healthy Minds Neuropsychiatry and Behavioral Sciences Center. He is a visiting professor of psychiatry, ERAS, Lucknow Medical College. He is past direct council member of IPS, just finished this year. He is guest faculty at Amity University. He is finance secretary of IMA Lucknow and also the finance secretary of IAPP UK chapter. Welcome, Dr. Alim and Dr. Amrit. Now I have the privilege to introduce our eminent chairpersons. Both of them have very brief CV being projected. Dr. Iyer Rajkumar from Baroda, who is a very close friend of mine. He is there with a mic in his hand and he can speak well and he can sing well also. Maybe now he's singing. And he's a consultant psychiatry, Alpha Healing Center, Baroda. Welcome, Dr. Rajkumar.
Good evening, sir.
And we have got with us Dr. Jyoti Sethi. He's professor and HOD psychiatry in Bharati Vidyapith, deemed to be university. It's medical college and Bharati Hospital, which is in Pune. Welcome, Jyoti. Welcome, Rajkumar. Now the program is yours. Please take over. I am muting to listen to you.
Yeah. Good evening to all of you. First and foremost, let me thank Dr. Topan Pati, Dr. Alim, and Dr. Amrit Joshi for having asked me to chair this session. We are going to sort of have a understanding of interpersonal psychotherapy. This is something which we have been dealing with day in and out in mild neurosis like depressions, anxiety disorders, dysthymnias, postpartum depressions, social phobias, post-traumatic stress. Perhaps interpersonal psychotherapy was initially developed as a brief therapy for depressions because people with depressive symptoms often experience problems in their interpersonal relationships. Interpersonal psychotherapy is a common treatment option for people experiencing depressions. Although depression itself is not always a direct result of negative relationships, relationship issues tend to be amongst the most prevalent symptoms during the initial stages of depression. To know something more about this and how it can be used in our day-to-day practice, we have with us a renowned faculty, Dr. Veena from NIMHANS. She is an associate professor of psychology over there and has been dealing with interpersonal therapies on a great depth. Her special interests would be epidemiology, drug policy, harm reduction, opioid substitution therapy. She is the Secretary General of the Addiction Psychiatric Society of India with more than 100 publications and papers being reviewed in journals, peer journals, as well as books, manuals, and monographs. She is a resource person and an expert for UNDOC, UNAIDS, World, WHO, and INCB. A principal investigator in National Drug Use Survey, British Medical Journal, South Asia Award for Non-Communicable Diseases Initiative in the year 2016, and a recipient of Venus International Medical Award 2019 for Excellence in Psychiatry. Veena, we are here to understand from you, unfold the interpersonal psychotherapy, eagerly awaiting to hear you. Over to you, Veena.
Thank you so much, Dr. Rajkumar. I'll just start my slide share. Thanks. Good evening to all of you. At the outset, I'd like to thank the organizers, Dr. Tofan Pati, Dr. Alim Siddiqui, as well as Amrit Pajoshi, who've invited me to be here amongst all of you distinguished consultants. I would also like to thank IPS Odisha State Branch for this opportunity to speak at the 35th edition of your Thursday Musings. The first time I heard about it, I was very impressed that it's already reached the 35th in the series of presentations that you've had. Thanks also to everyone who's registered today for your interest in this particular talk. I would like to highlight here that Dr. Rajkumar gave me a very kind introduction, but I think some facts have been a little misplaced. This is not the Veena Satyanarayana that's going to talk about interpersonal psychotherapy. I actually have expertise in women's mental health, not so much drug use and substance use as was mentioned. Perhaps, you know, it's just some information that got interchanged, but nonetheless, thank you, sir, for a very kind introduction, and it's my pleasure to speak to all of you today on interpersonal psychotherapy. I think sir gave a very nice introduction to interpersonal psychotherapy, so this approach may be familiar to quite a lot of you. It was developed for the treatment of clinical depression in the beginning, but subsequently has its applications for several psychiatric conditions. So, the scope of my presentation today will cover some of the interpersonal problem areas, the interpersonal formulation itself and interpersonal therapy, with a focus on, yeah.
Madam, there's a black box coming on the right side of the PowerPoint. Is it like it's is it part of the slide, or there's a, yeah, no, fine.
Is it okay?
Yes, madam.
Okay. So, yeah, so I was saying that finally I'll talk also about the focus characteristics of interpersonal therapy, goals, and also about how we generally progress with patients, starting from the initial phase of therapy over to middle phase and also the termination phases of therapy, just to give the audience a good understanding of how the progress of therapy really occurs. So we'll begin with a case illustration. So we have a middle-aged woman who's married. She has 2 children. She's brought to the psychiatrist by her husband for complaints of headache, tiredness, decreased interest in doing household activities, and also caring for her 2 children. She reports to have frequent crying spells, feelings of worthlessness, and also decreased sleep and appetite for the last couple of months. On further exploration, it appears that the patient is very withdrawn. Ever since she lost her job, she does not go out with her spouse or with her children. She has very minimal or need-based interactions with her family members. Now, because of these concerns, it has also caused a significant strain on the marital relationship. So this lady is evaluated for medication and she's also referred for therapy. So let's look at what kind of therapy is suited for this lady. Now, as mental health professionals, we always have a host of approaches in our repertoire typically. So one can think of a supportive therapy approach, a psychodynamic approach, a cognitive behavioral approach, a humanistic approach, or even a couples and family systems approach. And also there is interpersonal psychotherapy that we are talking about today. So let's begin by looking at some of the indications for interpersonal psychotherapy. So IPT clearly focuses on one of these 4 problem areas. We call it the interpersonal problem areas. So the first is about grief and loss. So ideally, the onset of depressive symptoms is correlated to an experience of bereavement. The person could be having grief reaction to the loss that they've experienced. It could also be because of interpersonal role disputes. Now, this is typically, altercations, difficulty in interpersonal interactions among family members or in the workplace and so on. We could also have a scenario where there is interpersonal role transitions. So these role transitions could be transition across different developmental stages or life cycle stages, or it could be transition like we saw in the case vignette. This lady held a job, she was okay, she was functioning well. Subsequent to losing her job, she developed depressive symptoms. So this could also indicate an interpersonal role transition. Finally, we have the problem area of interpersonal sensitivity or deficits. Now, this problem area suggests that the person could have some skill deficits, there could be attachment-related difficulties, because of which the person experiences a lot of loneliness, isolation socially, and is unable to, form relationships and also maintain relationships. So these are typically some of the considerations for why we choose the IPT framework. So looking at the formulation, just like we use the biopsychosocial approach in quite a lot of psychiatry to understand, a host of psychiatric conditions, even IPT emphasizes quite a lot on a combination of biological, social, and psychological factors that makes up a unique individual. And when that individual experiences one of these 4 problem areas, sometimes you could also have a person, having 2 problem areas. So for instance, somebody who's going through a difficult divorce, you can conceptualize that as an interpersonal role transition, but it could also signify grief and loss, a symbolic loss, if not a real loss of, a significant other. And this could lead to interpersonal distress and set off different kinds of psychiatric symptoms. And in this case, we emphasize quite a bit on clinical depression because this originated as a treatment for clinical depression. So this is broadly the IPT formulation. So we are all familiar that IPT was developed for treatment of clinical depression by Wiesman and Klerman. So some of the characteristics of IPT is that it is time limited. It's not a long-term psychotherapy. It's in fact a very brief psychotherapy, that could range, from, let's say, if you look at interpersonal counseling for very mild problems that we see in the community, that could take about 6 sessions or 5 sessions, to actual psychotherapeutic interventions that could go up to about 16 sessions, but on an average, about 12 sessions should suffice for most people. It is a very focused approach in that it focuses very heavily on interpersonal relationships, and we all know about the contribution of interpersonal relationships in developing psychiatric symptoms and also maintaining psychiatric symptoms. And sometimes interpersonal difficulties are also a result of, depression and several other psychiatric conditions. So the emphasis is in IPT is about here and now. It is about current interpersonal relationships and not like, what psychodynamic psychotherapy believes in about past interpersonal relationships and also about intrapsychic experiences. So personality is recognized as being important, but it's not the focus of treatment, and we don't aim for personality change when we do IPT. So how should an IPT therapist be? The therapist is active because this is a brief treatment. So the therapist does not have too much of a luxury of time. And in modern life that all of us, are living in today, it is really brief, short-term, time-limited treatments that are, a lot more popular than longer-term approaches. So the therapist is also a strong advocate for the patient. Sometimes the therapist does not believe in maintaining a very neutral stance. They speak for the patient, they advocate for the patient, and also the therapeutic relationship is collaborative, just like, we know of the cognitive behavioral approaches. So IPT helps patients improve functioning, particularly, like I said, in current relationships. It could focus on interpersonal style, which refers to a pattern across different interpersonal relationships, which is also referred to as the attachment style. And the attachment theory forms the theoretical basis for this particular treatment. So the focus is also on the functional role of depression. And one also looks at the bidirectional relationship between these interpersonal concerns and the onset of depression, and how after a person has been diagnosed with depression and along the course of this illness has interpersonal difficulties secondary to being depressed and experiencing some of these depressive symptoms itself. So the major goals of treatment is to enhance communication, enhance emotional expression, enhance one's own understanding of behavior in interpersonal contexts. So IPT assumes that by improving interpersonal relationships, symptoms and patients' life in general will also improve. So with this, we look at the different phases of treatment. Now, the initial phase is something that is going to be common to all kinds of patients that you would do IPT for. So irrespective of whether you're focusing on the problem area of grief and loss or the problem area of role transition or any other, the initial phase is likely to be the same across all patients. So in the initial phase, we begin by dealing with depression itself. So some of this I don't have to explain very much to this audience. The part about reviewing depressive symptoms, giving the syndrome a name of depression, explaining depression as a medical illness, and also explaining the treatment options that are typically available in this context. But what is unique to IPT is about explicitly giving the patient a sick role. So what do we mean by this? So sick role is about looking at the illness also as a social role, that a person is sick, that a person is ill. This is like any other medical illness. And perhaps the patient can benefit from getting some exemptions to performing their routine social obligations, which may be a little difficult when they are experiencing some of these depressive symptoms. Waiving off certain responsibilities or having a family member take over certain responsibilities of the patient. So you explicitly give them a sick role and tell them that it's okay temporarily to not do certain things that they are, typically used to doing. And over a period of time, how some of these roles and responsibilities can be resumed by them, typically at a stage when they start experiencing a reduction in symptoms and feel, interested in performing some of these activities. So one also at this stage evaluates the need for medication and takes a call on whether to put the person on some kind of a combination treatment or treat them exclusively with one or the other. So what is also important here is to relate depression to the interpersonal context. So we said that in IPT, there has to be some kind of a temporal correlation between the interpersonal problem area, whether it's grief or role transition or disputes, and the occurrence of depressive symptoms or symptoms of any other psychiatric condition. So what we do here is we actively explore past and current interpersonal relationships. Past relationships become important only if you're looking at some kind of difficulty with regard to attachment, which could have origins in the past. You're not working on changing those or discussing those very elaborately in therapy, but you're just looking at how that could possibly influence current interpersonal relationships of this particular patient. So what we do is we sort of start asking them about significant family members. We explore the nature of interaction they share with each of these members. We ask them about what could be some of the expectations in these relationships. Are these expectations fulfilled? Is somebody satisfied in these relationships? Or are there unsatisfying aspects of these relationships that could be contributing to the interpersonal distress or the psychiatric symptoms itself? We also look at what changes the patient wants in these relationships, which can potentially also impact the depressive symptoms and contribute to a reduction in those. So typically a patient would tell us, if only my spouse was a little accommodating, a little understanding, or if I had a better social support system, perhaps I would feel a little better. But right now I'm constantly confronted by loneliness and I'm not able to overcome depression as a result of it. So understanding what the patient wants and what is it that we really need to change for the patient to experience some amount of recovery from these symptoms becomes important. So the third aspect of what we do in the initial phase of therapy is about identifying the major problem area. So over here, we explore, like we typically do in a psychotherapy intake, about the patient's life, about the onset of symptoms, what was going on before the onset of symptoms, so as to make some kind of a correlation temporarily between the problem area, one of those problem areas that we discussed, and also the onset of symptoms. We determine which relationship or an aspect of relationship is related to depression and what might change it. What we also do is we explain the IPT concepts and contract. We explain to them about what IPT is all about, what are some of the goals, what as a therapist I think will be the focus of treatment going forward. We discussed that the focus is going to be on here and now, and it's important to elaborately discuss about some of these things that I mentioned in the slide concerning the length of sessions, duration, frequency, what to do if there is a missed appointment, the fee, so on and so forth, so that there are no problems that happen as a result of not discussing this later in the course of therapy. And you also set some reasonable expectations in the mind of the patient for what they are likely to expect from this particular form of treatment as we go forward. So once the initial phase is taken care of in roughly the same way, irrespective of which patient comes to us, we then hone in on a specific problem area. So predominantly we work on whatever is identified as the primary problem area. And so let's look at a case where grief has been conceptualized as the primary problem area. So A is a 33-year-old lady. She is a research scholar. She recently lost her spouse very tragically and very suddenly through a road traffic accident. And this happened a couple of months ago. And it also appears that she's lost her father in 2017, not so long ago. And she currently lives with her mother, who's also suffering from some chronic medical issues. And the mother is dependent on this patient. Her in-laws live in another state, but typically you can imagine that they're also likely to be as old as the parents, could be possibly having some health-related concerns and so on. And both her husband and she are the only children to their parents. So she pretty much is like, a significant support system, not just for her mother right now, but also perhaps for her in-laws. So she presents to us with symptoms of depression. And it appears that she's had a past history of depression. She was on medication, and she seems to have had a good response to, treatment of that particular past episode of depression. So what do we do in IPT for a person who presents with grief? So typically the middle phase of IPT occurs between, let's say, 4th session and the 12th session. The goals that we typically formulate in IPT for grief is about facilitating the mourning process itself, and also to re-establish this person's interest in her activities and also in her relationships, to be able to overcome in some way what she has lost. So some of the strategies that we use is we relate the onset of symptoms to the death of her spouse. So we reconstruct patient's relationship with the deceased, and we do this by very explicitly discussing about what was their relationship like much before this life event occurred. What was the nature of their relationship? What were some of the satisfying and unsatisfying aspects of the relationship? We discuss very explicitly about the circumstances that led to the road traffic accident itself. So what were they doing? How did it happen? Can they sort of discuss what that typical day was like for them until this life event took place? So in this particular case, this person, they were supposed to, go to a mall in the evening, but both of them overslept in the afternoon, and it was the wife's decision to go to the mall. But because they woke up late, they thought it would be a long commute to go to the mall, so they decided that they will just take a short walk near their house. And it so happened that this person was hit by a two-wheeler and he succumbed to severe head injury. So he had loss of consciousness almost immediately. He was taken to the hospital. He was declared brought dead. So one can imagine how traumatic this would be for the spouse, the suddenness of it, the unexpected nature of this. We also can imagine that she's quite likely to also present with some PTSD kind of symptoms. So we discuss all of this explicitly. We also discuss about cues that she remembers, of that whole incident. We also discuss very explicitly about what transpired following the death of the significant other. So that could be a few months, because this has happened a couple of months ago. So whatever has transpired since then becomes very important to discuss in therapy. So it's not just about a matter of fact narration of these events, which typically happens because by the time sometimes they come to therapy, they're already tired of narrating this to various people, let's say in the family or the friends or their colleagues and so on. So it's not just a matter of fact narration that is going to be healing. We know that. So it's important to discuss about associated feelings, associated cognitions. Are they sort of having associated behaviors of avoidance and so on? And it's also important to discuss how do we move on from here. So having experienced this tragic life event, having discussed all of this, what should be the way forward for this particular lady? What would she like, to define as important goals in her present as well as for her future? So all of those becomes important. And needless to say, the importance of a good support system for a lady like her. So she is now going to be the single breadwinner. She's already, supporting a dependent mom. She's going to have to support her in-laws. She requires a good support system for herself too, where she can talk about some of these concerns, have someone to share some of this with. So maybe her friends, maybe, some supportive colleagues in the workplace and so on can probably help her overcome her grief in the due course of time. So what could be some of the challenges? So typically when we discuss manualized approaches like IPT, everything is very beautifully laid out. It's almost like, in real life situations, these things just seamlessly fall, from one session to another. But we know that in reality, it could be very different. So although IPT emphasizes quite strongly on real loss or bereavement. What is also important is anticipatory grief, symbolic loss. So some of these patients who could be anticipating grief of a loved one because they have a terminal illness, or sometimes they have a terminal illness themselves and they're anticipating their own death. Difficulty experiencing affect because they are so used to intellectualizing everything that they're not able to emote. And how does one work on that in therapy? Because we know that real healing takes place only when people sort of connect with their emotions. They distinguish between what could be manifest emotions, latent emotions, and also sometimes they replace lost attachment figure with the therapist. And this lady that I discussed about in this case vignette is quite likely to do that, because if she does not have a support system and all she has is older parents who are dependent on her, she feels in therapy that this is one relationship where I can probably talk about everything, where I'm supported, where my emotions are validated, and this person is there to guide me through this. And so sometimes dependency in therapy can also set in. So this is about the problem area of grief. I just want to know if I'm going very fast or if it's okay, if there are any questions at this stage.
Absolutely perfect, madam.
No, we are going fine. Just the black boxes are still there. They are small, but still there.
The
Okay.
top in the right hand corner.
Okay, let me see. Is it still there?
Yes, madam.
Okay. I'm not sure how to get rid of that. Let me just exit.
Then continue, ma'am. Continue. Let's not lose time over it.
Okay. So it's not coming in the way of the text, right?
No, it is not.
Okay. So we move on to the next problem area, which is about interpersonal role disputes. So typically for interpersonal role disputes, I again have a case. Now this is a case of this lady who's a 50-year-old married lady. She presents with symptoms that are suggestive of depression. Her husband has been receiving treatment for bipolar affective disorder for many years now, and he's currently clinically stable. On exploration, we find that this lady has been having frequent altercations with her spouse over some recent discovery of a series of sexually exploitative behavior on his part towards their family members and also some of the friends. The spouse, of course, attributes this to the illness, while the lady seems to think that it could be otherwise. And she also says that she has ample evidence to say that these have happened when he's clinically stable, when he was not in an episode of hypomania or mania or any such thing. So let's look at what we do in the context of these interpersonal role disputes where two people are at loggerheads. They're having a lot of disagreements, they're having a lot of altercations, they're having a lot of fights on a regular basis in the household. So the goals would be to identify the dispute itself. We choose a plan of action, one of the strategies to be able to overcome this dispute. We also look at what are some of the expectations that these people having a dispute have of each other. What do they expect of each other? What do they expect of the relationship? We also look at whether there is any faulty communication that is going on, why they're not able to resolve it on their own. I'm sure they've sought the help of their family and friends, why they're not able to resolve it. And how do we really bring about a satisfactory resolution to this dispute? So first of all, like in IPT, like I said earlier, it would be important to relate the onset of depressive symptoms to covert or overt dispute with significant people in their environment or in their family. So I say that the dispute can be covert or overt because sometimes it's very obvious when two people come and consult with you, you know that there is something, amiss, and they are not hiding anything. They're quite open to talking about it. But sometimes disputes can be covert, and it may take you some time before you know exactly what the dispute is about. And once we know that, it would be very important to identify the stage of dispute. So people can be at the stage of negotiation where two people actually want to address this dispute. They know that there's something amiss. They know they're fighting more than they should be doing. And so they want to get help for it and they want to overcome this problem. Both people seem to be motivated to do so. Or sometimes you could have a dispute that's already gone cold. It's reached an impasse where in the past they may have tried to address it and it has not worked. And right now people have given up and it's just cold, but there is a little bit of, passive aggressive kind of behavior that could be going on. Or the couple could be looking at dissolution. So, they may have felt hopeless, that all their attempts have gone in vain, and, they're really looking at terminating this relationship itself, dissolving this relationship itself. So the stage where the dispute is can tell you how much you can still possibly do, how acute is it, how far gone is it, so all of this helps us determine what kind of strategies that we may want to use. We also may want to look at reciprocity. So whether these expectations are reciprocal, so whatever I'm expecting in the relationship, is the other person reciprocating that or not? Okay. Are my expectations realistic or not? Do I see parallels of this in other relationships, which could point to the role of personality sometimes? So you find that this person does not have disputes only in the marital area. This person is not able to get along with people or colleagues in the workplace, does not get along with friends or has frequent altercations in that domain as well, has had frequent altercations with parents and siblings as well. So this could point to a pattern or an interpersonal style rather than it being about, a specific relationship. We also need to look at how is this dispute perpetuated, what is maintaining it, what is keeping it going, which will then give us an idea about what needs to change to bring this, under control, or to, ensure a healthy interaction pattern in the family. So some of the challenges that we typically deal with is, sometimes patients report an absence of dispute. So in this particular case, the lady said that, this is happening not so much because of the illness of BPAD, it's happening because, he's choosing to do this. These are intentional behaviors, and I want him to recognize that and I want him to change it. Whereas the, spouse is saying that actually it is happening because of the illness. I have no control over it. I would like to, consult somebody who can probably run me through a series of tests and try to identify if, there could be, something wrong in one's brain, which could be responsible for these behaviors. So he actually says that there is no issue at all. There is no dispute at all. There is nothing for us to really work on in therapy. So patients could appear to be unmotivated for change, which again causes a problem. So first we need to enhance their motivation and then begin to roll out IPT like we discussed. Sometimes patients have overwhelming social adversity. So typically when we work with a lot of patients from the lower socioeconomic strata in this time of pandemic, there is loss of a family member, there is loss of a job, there is poverty, there is financial difficulties, there is a family to take care of, there is significant social adversity, and sometimes that could even make the therapist that the situation is pretty hopeless, and that could pose its own challenges to treatment. Sometimes we also have patients who undermine therapeutic process. Like I discussed in the vignette, now if the spouse is not going to cooperate, not going to acknowledge that there is a problem, is going to continue to be in denial, and is going to say that actually what I need is more biological forms of treatment, not so much psychotherapy, then that poses a challenge. And sometimes Patients also have an impaired significant other. So no matter how much you work with the patient, there is a significant other who is not going to change, and the person has to accept and live with that reality or terminate the relationship. So we move on to the third problem area of interpersonal role transition. So here again, we have the context of perinatal mental health, in which case IPT is also one of the evidence-based treatments that is often considered. So N is a first-time mother. She's a new mother. She's made a transition to motherhood. So that's the role transition that we are talking about. And she's had a girl child a couple of months ago. She presents with symptoms of depression. She feels that she's not good enough as a mother, and she constantly compares herself with her mother, who is helping her with childcare, like it often happens in our culture. And this patient feels that she is unable to bond with her child. My mother is able to do these activities with the baby so well, and I'm not able to do it. So I have a lot of self-doubt about my competency. I feel inferior in some ways. I start avoiding some of these activities involving the baby and so on. N was also found to be anxious. She's had a number of worries on her mind even during the antenatal period. And it seems to have gotten worse in the postpartum period, because in the antenatal period, she somehow seemed to cope with them, maybe because she had a good enough support system, or maybe her spouse was very supportive and so on. So let's look at what we typically do when we conceptualize interpersonal role transition to be the problem area. So here again, there is a lot of grieving that needs to take place. So there is a little bit of mourning about the old role, acceptance of the new role. So sometimes, people who are single get married and they have, some troubles, some difficulties in the early days of marriage. So you need to mourn the loss of this spinsterhood, bachelorhood status, now, being married, having a whole lot of responsibilities, finding it difficult to, strike this work-life balance, manage responsibilities of the household and so on. Similarly, for a new mother, it would be important to look at what life was when she did not have a child versus what is the change now that she has this baby to take care of. It's also important to help the patient regard the new role as more positive. So a lot of people may be looking at the new role rather negatively. And so it's important for us to help them make a realistic appraisal of the positive aspects of it as well as the negative aspects of it. It's also important to restore their self-esteem. So this lady is right now not being confident at all. She feels she's not good enough. She's not able to give the baby a bath properly. She's not able to nurse the baby properly and so on. So how do we, help her with her self-esteem? How do we help her develop a sense of mastery? That becomes very important. And so for this, we again tell the patient that the onset of symptoms has been following this particular role transition. A recent life event has taken place, or there is a significant change in one's life. We help them look at and make a realistic appraisal of the positive as well as the negative aspects of their earlier roles as well as the current roles. We look at this also as a time of grieving. Like I said, it's important to, explore the sense of loss, the change itself, the opportunities in the new role, and what are some of the skill sets that they need to learn and master to be able to perform the new role as competently as possible. Okay, so this could be even in the workplace. Everybody is used to, a paper pencil based system, and subsequently everything gets digitized, and they may find this transition to be very difficult. This pandemic also has been a time for all of us to learn a lot of digital methods of communicating, continuing to do seminars and webinars and conferences. And for some people, maybe this transition has been difficult. It's important to help them connect with their emotions again and release some of these emotions in a healthy way, express some of these emotions in a healthy way, and also to look at how do you build a new support system, how do you build your new set of skills that will be important to perform this new role as effectively as possible. So here again, there would always be some challenges. Sometimes patients don't recognize the role transition itself. So while you're trying to tell the patient that the role transition caused the depressive symptoms or contributed to the depressive symptoms, patient says, no, actually, it's not the role transition. It is probably grief or probably the disputes that I'm having with my mother, because we don't seem to agree on how to take care of this baby. We don't agree on our plan to bathe the baby. We don't agree on our plan to create a routine for the baby and so on. So sometimes that could be a conflict, but it's always important to go with what the patient is saying so as to, restore that therapeutic alliance also, and gently, see what kind of adjustments need to be made, what needs to be considered to be primary, what needs to be considered as secondary, and so on. So patient sometimes does not even recognize or accept positive or negative aspects of a role. So sometimes they glorify everything. We know that in our culture, motherhood is glorified. So family expects them to be a certain way. They also put a lot of pressure on themselves to feel good about spending time with the baby, whereas they feel otherwise. And that dissonance causes a lot of emotional labor. It causes a lot of undue stress. And so some of these, emotions can cause a problem in therapy itself. So moving on to the last problem area, which is about interpersonal deficits. Here we have a young adolescent girl, and I've used the illustration of a adolescent because IPT is again an evidence-based treatment for adolescent depression. She's the adopted child of her parents. She was adopted when she was about 4 years old, and the parents seem to have struggled, and parents seem to have, I think there's an error there. Patient seems to have struggled to make friends growing up. Okay, so she's not been able to initiate relationships. She's not been able to maintain relationships with her friends. She presents with symptoms of depression. She reports feeling very lonely. Her parents are busy in their professional life, but they're trying to do their best for this young girl. The girl, however, says that she doesn't feel very close to anyone, including her parents. So in terms of interpersonal deficits, what we hold as important goals will be to reduce patients' social isolation. So this young girl could be isolated. She could probably have acquaintances, but she does not feel close to them. She does not have any close confiding relationships. She does not even feel close to her own parents. We also try to encourage formation of new relationships because we believe that a good support system is important for individuals to be healthily adjusted in their own environment. So some of the strategies that become important again is to relate the onset of problems to social isolation, a feeling of unfulfillment in relationships, a feeling of loneliness that they experience, lack of a support system. I don't have anybody to go out with. I don't have anybody to hang out with. And this has become a predominant concern for quite a lot of patients in an urban setting. So typically, if you look at the example of urban metros, a lot of people migrate to metros for the purpose of education, for the purpose of employment opportunities, through marriage, and so on. And they're leading very isolated lives. And after a certain age, they're having some difficulty expanding their support system, forming new relationships, and so on. So irrespective of what you do in the 1 hour of therapy, these people go back into a reality which is very lonely. And that can pose a big challenge in therapy itself. becomes particularly more challenging where patients also have deficits because of which they've never been able to form attachments. And that can also manifest in the therapeutic relationship itself, which is again an interpersonal relationship. And if this person has not formed any attachment growing up, they're quite likely to also have difficulty forming this bond with the therapist in therapy. However, it is still important to review past significant relationships to see if this is a pattern or if this is something that is more recent, for us to look at negative and positive aspects of it, to look at repetitive patterns in relationships, and like I said, to constantly juggle between looking at positives, looking at negatives, so as to make them have a very realistic appraisal of their situation. So some of the challenges here is that the therapeutic relationship itself is poorly developed, like I said, for the reasons I mentioned, that the patient is not able to form a relationship, and even therapy is an interpersonal relationship. So it requires the patient to trust, to have some, self-disclosure in the context of therapy, to feel comfortable talking about her problems and so on. Does not follow through with therapeutic directives. So no matter what you're saying, session after session, you find that there is no work happening from the patient's side between these sessions. So pretty much you end up repeating the same thing and the patient is not putting any of this to use or implementing any of these strategies in their own real life. And ultimately, the patient could even drop out of treatment. So now that we've discussed what the meat of IPT is about, the meat of IPT is really in the middle phase of therapy, where you're trying to very actively work and resolve one of these 4 problem areas that we discussed. We come to the termination phase, which is typically, something that happens again over 2-3 sessions. Here again, we review depressive symptoms. We try to take stock of how much this patient has improved. Have her symptoms not improved at all, or do you see a worsening in symptoms? Now, all of these are possibilities. We discuss early signs of relapse, and this becomes important because we are talking about depression, which is an episodic illness. We discuss explicitly about termination. We acknowledge the fact that termination is also a time of grieving. It is, again, another symbolic loss that some patients, view it that way, and they have to go through that process of grieving as well. It's also a time for the patient to acknowledge and accept and feel good about their own mastery, their own independent competence of, handling their real life situations. There is always non-response. We know that, if 2/3 of people benefit from this treatment, there is always 1/3 that does not do well with it. So there is non-response that we need to deal with. We need to have a very explicit discussion about non-response. What could be the reasons for non-response? And what could be the way forward? Do we want to try something else? Do we want to, revisit this entire thing? Do we want to make some changes in the medication? What do we want to do? We also discuss about continuation, booster sessions, maintenance treatment, which again happens over a couple of sessions, but at a lower frequency. So if you were seeing your patient once a week in maintenance phase, you're quite likely to see them maybe once in a month to just see how they are coping in the absence of regular therapy sessions, and whether you want to emphasize some of the important take-home messages from the kind of sessions you've had so far, reinforce some of the good things that they may be doing so that you validate that, you encourage them to continue doing some of those practices, and you encourage and reinforce them for bringing about some positive changes in their life. So that brings us to the end of these 3 phases of therapy. In terms of the techniques that IPT uses, it's nothing very, very unique. IPT is more an approach to treatment. It is not very technique specific. So it's okay. IPT therapists typically say that you can borrow techniques from other schools and typically from cognitive behavioral approach. So if you look at the techniques that I have here, it's important to carry out a good communication analysis, particularly when there are disputes. It's very important to understand what happens. And interpersonal incident analysis also becomes important for the same reason, where you take some recent examples and you analyze them and try to understand when this happens, how does the patient react? How does the significant other react? What is a likely resolution of these interpersonal disputes or incidents that take place in the family? Who tries to win typically, who gives in? All of these things are discussed very explicitly with reference to very concrete interpersonal incidents. So a couple of times I mentioned the importance of emotions, using affect, ensuring that the person is able to label their emotions accurately, identify, even if it is manifesting as anger, that there could be something going on at a deeper level which could indicate a sense of hurt, a sense of disappointment. So accessing both latent as well as manifest emotions become important. Role plays are very important because sometimes it's important to do a little bit of skill building in the therapy sessions before they can practice something in their real life. So to help them develop mastery and competence, we use role plays. This could be about, let's see how you can negotiate better for what you want with your spouse. So let's try and do it in the course of therapy and see how you can take it forward in your real life. We use problem solving as an important technique where the person is looking at not just the immediate alternative that comes to their mind or the only alternative that comes to their mind, which often happens in the context of depression, but to also get them to look at all the other alternatives there could be to potentially solving this problem, for them to look at the pros and cons of each and choose a particular alternative that holds the most promise for them. Homework assignments are also used like in CBT, but here the homework assignments tends to be more about interpersonal situations embedded in the interpersonal context and not something that they just reflect upon and write down in their journal or in their book. Now, using the therapeutic relationship itself as a tool also becomes very important in this kind of therapy because, like I said, the therapy rests heavily on interpersonal relationships, and the relationship between the therapist and the client also for that reason becomes important because it is an interpersonal encounter. I can go on to discussing about these techniques a little in detail, but I think because I've given a good overview and I want to leave adequate time for discussion, I will stop here and take any questions, comments, or if people want to share the patients that they may be currently working with, or if anybody has tried IPT and they feel it works or doesn't work, we can take up any of these.
Yeah, Jyoti ma'am.
Yes. Thank you, Dr. Veena. And that was wonderfully elucidated with all the cases. I especially like the way that you approached, with the different types of techniques that we can use and each case going into each session. I think there are some comments in the chat box from what I can see. I also have some questions actually. This is specifically, this is something that was asked in the session, in the chat box also. What is the right time for actually starting interpersonal psychotherapy in a case of depression? One. And are there any cases where you do not do you don't dwell into interpersonal psychotherapy? Is there any sort of, time that you would not actually look into it, or look into it as a form of intervention?
Okay, so thank you for those questions, very important questions. So the first one is about, when do we really do IPT? At what stage do you consider IPT? So typically, I guess, when a referral comes in, and then, you spend an hour or two sometimes talking to the patient, you identify an interpersonal focus. So like I said, I've discussed about the problem areas. So if you feel that one of those problem areas could in fact be contributing to this person's symptoms, so that's when you start thinking about IPT. And in terms of contraindications for IPT, there is no real contraindication as such. Most clients seem to take to IPT well because it's a non-threatening kind of an intervention. Unless you do feel that there are very strong psychodynamic issues that requires attention, and it's really important for you to address the past, and you can't really keep your focus on here and now. So those are situations where you probably will emphasize more on, therapies that look at intrapsychic factors and not so much just here and now interpersonal relationships.
Yes. Another one question that I wanted to ask was, uh, how do you see, like, since this is about interpersonal, relationships, I think there was a question about whether role play is something that I think we can employ. You said it in your summing up also. What about when it is the therapist who sort of identifies with the client's problems, and there could be a subtle amount of collusion? So to what extent can you actually prevent this from happening, even in, like, I don't know how many young psychiatrists are there and psychologists. So this is about, with respect to peer reviews, need for supervision, at what level do you say that, okay, you do not need that supervision? And then how can we work peer reviews with regards to individual cases? I mean, as a medical college teacher, I think I would look at it from the students' perspective also, when you are sitting and training them.
Yeah. So I think that's also very valid. And I think not just from the point of view of youngsters who may be practicing, but also from a point of view of senior people who would just like to, sound it off with their colleagues and get some peer review and validation about some of these newer treatment approaches that are coming up. There are a lot of newer approaches to psychotherapy that are coming up, and one can't hope to master everything as well. So I think the important point here is to probably get into some kind of peer supervision wherever there is a problem. Of course, if everything is progressing seamlessly, okay, you have some experience in this and you know that, the patient is benefiting from these sessions, you may just continue. But if you have certain challenges and if you have some roadblocks, it's not a bad idea, irrespective of, one stage in one's career, to just have a discussion about what is going on. Of course, in some settings these automatically happen because you're working in a team, and in some settings, people can become a little isolated, like in private practice. But nonetheless, the good thing about IPT is it's very structured, so even a youngster, even a beginner therapist can practice this reasonably well, because it's very well laid out. If you look at the manual, you know exactly what you need to do one session after another. Of course, in reality, like I said, it may not always progress like that. You go into therapy with a certain agenda, but what your client brings takes you away from that agenda, and you may have to, address some other problems sometimes. But I think, like CBT, IPT is also very structured, so that offers, some comfort for youngsters. But in terms of supervision, I think it would be important at all stages. Whenever you feel the need for it, it's important. And also about transference sometimes that can happen in briefer therapies. that is also important, but in IPT, we don't get down to interpreting transference like we do in psychodynamic therapies. We recognize that it is there, and if it is a positive transference, it could potentially be good for you to help your patient achieve the desired outcome. If it is a negative transference, it would still be important to catch it early to see if you can do something about it so that it doesn't jeopardize what you have planned for the remaining sessions of therapy, so that it does not cause a dropout and so on. So rather than interpreting, you're just aware of it, and then you take the necessary action early to ensure that the outcome is still likely to be good.
Yeah. Just one question before I think I'll Dr. Alim and Dr. Amrit can go on with the questions. Just one question I had is, since you talked about grief and it's in the middle part of the session, is there any scope for abbreviating this? For example, you're working in women's mental health, so when you talk about a bad obstetric history with multiple losses, abortions, for example, someone who's undergoing infertility treatment. So is there scope for actually doing this in terms of a preventive role in preventing depression, which could come up, or in helping helping the person adjust better to the loss events? Is there any scope for that?
Mm-hmm. That's also a very important question, because sometimes we have, as mental health professionals, an opportunity to prevent something. So we need not wait for a full-blown episode to take place before you start rolling out your treatment. And we are also at this point able to identify some at-risk groups. So infertility definitely is a time where a lot of women do become vulnerable. So interpersonal psychotherapy does talk about anticipatory grief, and that component is highlighted also in the context of people receiving assisted reproductive treatments, because we know that not all treatment efforts are likely to be successful, and there is a lot of grieving that is likely to take place with the many cycles of IVF and so on. So anticipatory grief can be addressed like that. What we may want to call it is more like interpersonal counseling. Like in terms of dosage, it may be just a few sessions, because this person right now does not have full-blown clinical depression or any syndromal psychiatric disorder. So you may call it a low dose counseling of an interpersonal nature, rather than calling it IPT itself. But there is definitely an opportunity for that.
Thank you very much. I think I will hand over to Dr. Alim and Amrit for the question.
Thank you, ma'am. Thank you, ma'am. Ma'am, if I go to the junior resident level, you talked about 4 things: grief, disputes, transitions, and deficiency in the interpersonal relations. So all of the people have to pass through these stages sometime. So why do few people, why should people need IPT? Who are those?
Okay, so very important, for us to look at vulnerability or risk factors. So I think this points to that some people, irrespective of the kind of adversity they experience, they turn out fine. But there are a lot of other people who probably don't follow the same pathway. And a host of factors could be responsible for that. It could be about the kind of interpersonal relationships they've had, the difficulties in attachment. We know that attachment theory constitutes a very strong theoretical base for this treatment of IPT itself. So a lot of it can boil down to not being able to form adequate attachments, not being able to initiate relationships or maintain relationships, not being able to have healthy relationships. Like for instance, you see in the context of even personality disorders. Now, IPT has been extended to the treatment of EUPD, borderline personality disorder, where the origin of problems have a developmental onset. So I think even in those cases, looking at how all of this has built up over a period of time, what are some of the vulnerability and risk factors that make this person develop depression, whereas somebody else is all right, I think would be important. And of
Thank you,
course,
madam.
when we look at predisposing factors, it is biological, psychological, social. So it's important to, give due credit to each of those.
Yeah.
Amrit.
In the second slide, of course, you had explained everything, madam. You've given a good chart about how biological factors, environment, and all have come. Salim, please go back to the drawing board and read whatever madam has told.
So then let me add a question, ma'am. What if I give a tablet? It is an improper question. What if I give a tablet and his depression clears out and there is no need of IPT? So how do you think of this as an approach?
I think that's a fantastic approach. That is really a good approach because psychotherapy is not easy for people to engage with because a lot of what is discussed in psychotherapy is unpleasant, right? Whereas when it comes to just gulping down a medication, it's easy, isn't it? But unfortunately, interpersonal relationships don't get better that way, right? One needs to learn skills, one needs to, probably become a little insightful about what is going on in one's life. Of course, medications help you do all of this. It helps you participate in therapy. It helps you look at all of this with less anxiety. It helps you collaborate with the therapist. It gives you the confidence also to bring about positive changes. So I would actually advocate combination treatment or sometimes even psychotherapy alone.
When I'm not motivated to change, how will you motivate me?
Yes, so we do have a lot of patients who are not motivated to change. And I think I also discussed a few case scenarios where, this is an issue. One can always try to motivate. There are, various methods by which one can motivate a patient to, change some of their ways of behavior. So I think the effort from a therapist will always be to be hopeful and optimistic that change is possible and to attempt to do it with, as much sincerity as possible. But despite that, there will always be situations where somebody does not want to change and we have to accept that.
Amrit.
Madam, so if due to depression there are interpersonal issues, we can think of the pill. And if due to interpersonal problems there is depression, we can think of IPT and pills. That is what I will assume.
Yeah.
An interesting question, madam. Away from the grief, mourning. So one question has come in the chat box: how to manage interpersonal relationship issues due to infidelity? I mean, infidelity is quite common. Now we see maybe 20% of the cases we see are maybe related to infidelity.
Mm-hmm.
But if partner does not acknowledge that infidelity is an issue, wants to continue his or her marriage and also the affair. So how do you manage? Excuse me.
So we need to understand that IPT typically is an individual-based therapy. So we are not trying to do couples work, although all couples work and family work is also an interpersonal psychotherapy itself, because you're very actively trying to work on interpersonal relationships. So let's say, a lady presents to you with depression because her spouse, has these extramarital relationships and she is distressed as a result of it. One option is possibly to look at the spouse's readiness also for treatment and to see if you can involve the spouse. Let's say sometimes the spouse is willing, they're willing to address it, they're willing to engage in a very transparent conversation about it and, either convince this lady that they would like to go ahead with both these relationships or convince her that they're willing to let go of one and go along, with the marriage. So there could always be various possibilities. And if we assume that we only have access to the lady because the, spouse is not willing for treatment, is becoming very defensive, is going to feel that the therapist is also going to hold them responsible for whatever has happened, and so they don't want to participate in treatment, it is still possible to work with the wife alone for her to, make some sense of what does she want out of this? How is her suffering going to come down? What are the different possibilities before her? that she can negotiate with the spouse, if negotiation is still possible. Like I said, in disputes, it could have reached an impasse. Maybe she's tried to negotiate, maybe she's tried to do several things and it has not worked. And right now it's gone cold. So what do you want to do about that if you're looking at it as a dispute? Or, if you're looking at dissolution, a lot of people have decided to dissolve the relationship, and move on. So that could also be, an option for the lady to consider. So I guess therapy is about helping her look at all the alternatives that there are, helping her look at how this has caused some kind of an emotional injury, attachment injury for her. It's led to a sense of betrayal. It's obviously led to a lot of anger, disappointment, sadness. And how does she think that all of this is going to reduce going forward? What does she need to do? What does the spouse need to do? And what is realistic given their, story, their willingness to change?
Yeah.
Now, very practical issue we often face in the OPD. Suppose a lady is there and complaining of anxiety and depression-like symptoms. Now, it turns out that she is very distressed by the mother-in-law's behavior. But everyone is saying that she is old, she will not change, why don't you change? So this is a common theme that we see in the clinics. So, ma'am, how to approach this thing? The daughter-in-law and mother-in-law issues.
Again, culturally, I think this is very important. So everybody pretty much goes through a cycle where there is a lot of overt conflict, and then either they sort of reach that stage of acceptance that you have said, where they think that because of the mother-in-law's age, she's not going to become a different person suddenly, and one has to accept and see what adjustments they need to do in their life to be able to cope with this problem. On the contrary, sometimes, people have tried to engage in family therapy where you're also soliciting the participation of the mother-in-law, wherein the mother-in-law also gets to understand, from a position of empathy, what this is doing to the lady, and can some agreements and some adjustments can be brought about. So that's also a possibility. So I think, either acceptance, again, we come back to the same thing. Negotiation is the first step. How do you negotiate for what you want? What have you tried? Has it worked or not? If negotiation is not possible, it's reached an impasse, are you willing to accept it? Again, it's the lady's choice. Some people accept it and they just continue with their life, but they just don't personalize everything. They figure out other ways of coping with it. They try to find their peace and comfort, elsewhere. And sometimes it could also lead to a dissolution in very severe cases where they feel that this is not something they can put up with. So I think, the patient takes a call on which of these, directions she would like to take.
And many of the patients are not in a position actually to take a call. They are so much surrounded and so much bounded that they can't make a decision. Only the family is making a decision. So I think it creates a very distressing situation for me also. So how it becomes difficult to handle.
Yes. It is true that, when a person is very acutely ill, obviously they're not in a position to help themselves very much. So I think decisions have to be left for later, when some amount of reasoning can take place, when emotions have taken a backseat. So at that point, I think it would still be important to try to empower the lady if you're able to do it. Now, a lot of people cannot be empowered only because they have some deficits, and this could even be cognitive deficits, because of which you hit a roadblock. There's nothing more you can get across to this person just because there are certain limitations that you're dealing with. In which case, of course, it's okay for the family to get involved, and we hope that the family is doing whatever is right, also keeping this patient's interest in mind. But we would still try to empower a patient to take her decisions as far as possible.
Thank you, ma'am.
But of course, decisions in our culture are always taken collectively along with significant family members. So that is also encouraged.
Yeah, one or two interesting questions, madam.
Yeah.
How important is the matter of establishing relationship with the inner self in IPT? Is it relevant?
Sorry, if I understood your question correctly, how important is it to establish a connection with the inner self?
So it's like an interpersonal, the inner self and
You mean to say intrapersonal?
yeah.
Okay.
There's a twist in that question. That's
Okay. So I guess when we're talking about interpersonal relationships, always the self is important, isn't it? It's about the self and other, like we understand in, the perspectives of object relations, self-psychology, except that we are not getting into a lot of intrapsychic interpretations here. You're becoming aware of yourself, the contribution of yourself, to these interpersonal scenarios. And what is it that, you may also be doing, that is contributing to the problems, and where is it that you can also change? So to that extent, self-awareness becomes important. But like in psychodynamic psychotherapies, you don't get down to analysis of self very much, and you don't get into personality change in the context of IPT.
CBT versus
Yeah, Amrit, please.
I'm asking questions from the chat box actually.
Sure.
When to use CBT versus IPT, and then when not to use IPT is another question that has come up.
Okay, I think I've answered when not to use IPT unless you feel that interpersonal problems have not had a major role to play either in the origin, development, maintenance of the problem. Then you don't really need to use IPT. Perhaps other approaches like CBT, psychodynamic, all of that becomes more relevant in those cases. Sorry, what was the first question?
CBT versus IPT.
CBT versus IPT. Yeah, CBT versus IPT. Now, if you look at the techniques that IPT uses, there is a lot of similarity with CBT, except that CBT is again a little intrapsychic. It's intrapersonal, I would say, whereas IPT is interpersonal, isn't it? So CBT is really a treatment where you think there is something amiss with the person's cognitions. So this is about intrapersonal factors, your own cognitions, okay, which could be a little distorted. There could be unrealistic appraisal of events that you're making as a function of depression. You find that there are cognitive schemas that are responsible for certain, appraisals that you're making now, which could indicate some cognitive errors, like, all or none thinking, for instance, maximization, selective abstraction, and so on. So all of this is about internal processes, whereas interpersonal psychotherapy is more about social interpersonal domain. It's about relationships. It's about the environment. It's about the milieu. It's about external factors. So wherever you feel those are predominant, then you use IPT. Wherever you feel it's the internal processes that are important, you choose between psychodynamic or cognitive behavioral. Okay,
Yes.
I hope that
Ma'am,
answers.
you've been using IPT at NIMHANS. So is there any data, or if not data, your personal experience regarding the success of IPT, failure of IPT, incomplete treatment or dropouts? So what is your experience or any data in this regard?
Yeah. So I think from our own experience at NIMHANS, like I said, the world that we live in today, a lot of people prefer brief therapies. And IPT, like I said, is a brief psychotherapy. But brief psychotherapy also means that IPT is a treatment that goes on for 16 sessions as per the manual. So our patients don't think 16 sessions by any stretch of imagination is brief. So they are looking at, briefer formats, like maybe 5 sessions, 8 sessions, maybe if you stretch it up to 10 sessions. And there are a lot of challenges, for them to keep appointments. And now with the pandemic, we started doing a lot of telephone and video-based sessions. So even after things have gotten better, everybody only wants video-based sessions because the time that they're spending on psychotherapy is less. They just have to commit to that 1 hour, and they don't have to, waste another 2 hours in the traffic of Bangalore city, where they have to lose an entire day or half a day and so on. But also in the context, so I also practice in the perinatal mental health unit, where again, for pregnant moms who are on several kinds of restrictions by their gynecologist against travel, again becomes a challenge for them to come for these therapy sessions in person. So we try to do briefer psychotherapy. Sometimes it need not even be one whole hour of psychotherapy. It can just be half an hour. Sometimes mothers with very young infants, how are they going to have the luxury of time to participate for a whole hour? So we try to come up with as many adaptations to the rule as possible, just to make it work, keeping in mind the patient's genuine needs and concerns. But in terms of data on the effectiveness of IPT, I think it is something that can be done. I think can be easily taught to postgraduates. Postgraduates can be easily supervised to do this kind of work. And it has also shown us some reasonable effectiveness, both in the context of, clinical depression, in the context of perinatal mental health conditions, in which I've tried to do quite a lot of this, and also in the context of adolescent depression. I think the rates are reasonably good. But like I said, there will always be some people who don't benefit with a certain approach, and that is true even for IPT.
Amrit. Thank you, ma'am.
So you would always prefer IPT whenever a situation comes. You find it to be time effective, cost effective, and therapeutically effective, madam. Like,
I definitely prefer IPT as an approach, also where, the patients require this kind of approach. So, because I'm not, practicing only IPT, I also do CBT where required. I also try to do a little bit of integrative therapies, which practically becomes very useful in, conditions where there are a lot of comorbidities to consider. There are axis 1, axis 2 issues, so you also need to integrate various perspectives, but to know what perspectives you want to integrate, the timing of what you want to use when with a particular patient, all of that requires, some careful consideration. But I don't see myself exclusively as an IPT therapist, although I have received training in IPT, and therefore this approach comes a little more naturally to me. But ultimately, whatever the patient wants, we try to do that as far as we are also aware of those approaches.
and my last question for the evening, madam, a simple question. You are in Imams, you have a full team, madam. Many of us are standalone psychiatrists, or many of us maybe work with a counselor or a psychologist. And it's a very, very important aspect which you have discussed, the interpersonal relationships, what Alim was talking about, mother-in-law and daughter-in-law, grief, marriage. We see marriage is another, childbirth. We've gone through different things where actually we see the problem. So as a standalone practitioner, as a standalone psychiatrist, can you just tell us in brief, how briefly, or maybe 2 or 3 sessions, if we have to manage somebody in 2 or 3 sessions or 4 sessions, how we can do it, how we can go about it, madam? And that will be my last question, madam.
Okay. Thank you, Amrit. I think that's a very important question because as we know, we are not going to have patients coming to us for too many sessions. So whatever we need to do it as effectively, assuming that this person is not going to come back. So sometimes, it's just enough to probably help them make an association between the interpersonal context or these problem areas that I spoke about and the symptoms that they are experiencing, and for them to really think about what needs to change about their situation right now for them to feel better, and how are we going to bring about that change. What is it that they can do, and what is it that their significant others can do, and probably just leave them with 1 or 2 strategies that they can possibly do. So although sometimes in NIMHANS we do have a luxury of time and a full-fledged team, it is still important in the outpatient setting. Let's say somebody comes for a follow-up, you may convince them that they may require therapy, but who knows whether they will come back to you again. So I still think it's important to treat every session as complete as possible, to the extent possible, and definitely not spend too much time just assessing, but also leave them with one or two quick strategies that they can quickly put into practice.
Yeah, thank you. So my last question, we ask it to almost everyone. How much should one charge for a one session of APT?
The question prompted by his better half.
I wish there was a straightforward answer to that, but I'm sorry, I can't be any wiser than, all of you already know about charges. So I think it's important for patients to see this as a treatment. A lot of times in our culture, people don't even see psychotherapy as, a treatment. And so it is important to formalize it. It is important to make it professional. But charges, again, differs from setting to setting. Whatever you think is reasonable, I think you will anyway go with it. So
Okay. Thank you, ma'am. Thank you.
thank you.
Should we hand over to Jyoti,
Yeah,
ma'am?
chairpersons, then Dr. Tufan sir will take.
I think Rajkumar sir had to leave for an emergency. So Jyoti ma'am is there. Ma'am, please.
Yeah, thank you very much, Dr. Alim. At the outset, I would like to thank Dr. Tofan Pati, Dr. Alim, Dr. Amrit for actually inviting me to chair this session. It's been a wonderful session, Dr. Veena, and extremely clear, elucidated so well with all the cases. In fact, you made it sound so simple. I'm sure, like I think some of my PGs were listening in. It looked like anyone could do this therapy, and it was extremely simple. It was very good. And I think we seem to have covered all the questions, and I'm very happy that this has been such a great session. Thank you very much. And I'll just hand over to the organizers. Thank you.
So much.
Thank you, madam. Dr. Tufan sir, our organizing chairperson, sir.
Dr. Rajkumar is there. He can have his comments if you like. Then I shall. Dr. Rajkumar.
Sure. Sir,
Okay.
you can.
So it has been a fantastic session, highly enlightening, highly interesting. And I thank Dr. Bina for the presentation. I would like to have one clarification. As it is a structured therapy, there must be manual. Is there any Indianized manual for this?
So there is no Indianized manual, but Dr. Vikram Patel has used the interpersonal counseling in his Manas trial. So for that, he has come up with some adaptation, but that was, of course, a research study and all of that. We don't have any Indianized manual, but we do try to adapt, like I said, based on client needs.
So it should have an Indianized manual, which. And
Yes,
next to
that's a good
clarify.
feedback.
Yeah. And another clarification: who can give IPT with the shortage of psychotherapists and with the paucity of time? Is it possible that non-mental health professionals can give supervised IPT?
I think all mental health professionals obviously can, offer IPT. But if we want to include non-mental health professionals, then I guess in a lower dose, like I was referring to the interpersonal counseling, I think that can easily be given, and that was demonstrated also in the Manas trial. So I think to address the country's need, we do need people, who can be trained to deliver this in lower doses.
But I mean, in that context, can you comment upon the WHO's advocated group IPT?
Yes.
That they have told, and Shekhar Saxena was one of the pioneers in producing that document.
Group IPT is a useful format. I think as long as we have a relatively homogeneous group, it can also be cost effective. And group treatments, let's say even in the community setting, can be of great value and very cost effective. So I think, I would definitely, appreciate that adaptation to IPT.
Thank you, madam. Thank you so much.
Thank you. Thank you so much to all the organizers for having me here today. It was absolutely a delight interacting with all of you and also learning about all of your experiences. Thank you.
I'll say a formal thank you, madam. Some people are asking for some good resources.
Huh.
For if you can share one or two resources.
Sure. Is there an email ID I can send it to, which you can then circulate?
In the chat box, if you can share, we will mail it to all participants.
So I think in that case, I'm going to share these slides that I used, and I would like to email it because it'll take me some time to access it and put it in the chat box.
You can mail it to us, madam. We'll do it. I'll send you a mail.
Sure.
One last question I have to ask you, madam, because our main person is asking me to ask you this question. How directive the therapist has to be in IPT?
Okay. I think this also I covered in the presentation that an IPT therapist has to be active because this is a brief treatment. So there is no luxury of time. It has to be collaborative, like, in CBT, and also the therapeutic relationship itself, because it's a interpersonal, relationship, has to be, strong enough to bring about positive changes.
Thank you. Thank you, madam.
Thank you.
On behalf of the entire team, I would like to thank Dr. Veena. I just gave her a phone call. She didn't know me. With brief introduction, she agreed. And there was some miscommunication. She was going on the train, and then she agreed for this session. Madam, it was superb. It was so simple. It was so lucid. We felt as if we did not learn anything, extra, but everything was there, and then you just guided us so well. Thank you so much. Thank you, Dr. Rajkumar. Dr. Jyoti Sethi, thank you for taking away some of the questions which Alim was going to fire. It's always nice to ask 9 questions, and he allows me 1 question to ask. Thank you for being such a great moderator. Thank you, Dr. Tufan sir, for getting us some different viewpoints, including group IPT, which we might have missed. Thank you to our audience. We had more than 280 logins, madam, today. That is wonderful. We had maybe around 400, people who had registered for this event. Thank you so much. We would also, there are a lot of people who have been mailing me asking you to ask you for another session, whatever it be your choice, madam. So you can just tell us what will be your next session. Maybe in a couple of months we'll be calling you. So what would be your area you want to speak, madam? Please do share with us. People have been messaging me, texting me that to call you again. So it has been an excellent session. Thank you, IPS OSB, Torrent, Pavan, and myself and Alim. I cannot thank myself enough. So thank you so much. Have a happy Holi. Please stay safe. Please play properly. Good night, everybody. Hope to meet you next time.
Next announcement. Next speaker.
We have a wonderful session.
Thank you.
Can we share this screen share for the next session?
Thank you.
Yeah.
We have Dr. B.N. Gangadhar sir for the yoga and clinical psychiatry. That will be a wonderful session. So we invite all of you to attend. It is not an April 1st joke. Sir also told me.
Let me say this, because if you say this, it becomes a joke. Chalo, thank you so much, everyone. Thank you so much.
Thank you.
Good night.
Thank you, ma'am. Very nice interacting with you. Thank you, all of you. Tufan sir, thank you. Jyoti ma'am.
Yes, thank you.
Thank you, everybody.
Good night.
Thanks, everyone.
Bye.
Thank you.